This week on the BackTable podcast.
They found pretty much in lung, liver, spleen, kidney, all of those tissue had microplastic in the tissue deposited. That's not a normal occurring phenomenon. So we know it's something that we're ingesting. And of course, as the plastic use increases and we have them in our landfills, they're going to get broken down into these microplastics and get absorbed into our bodies. We all understand the concept of tumor microenvironments. And so these are considered foreign objects, right? Microplastics aren't normal. They're not natural occurring things in our bodies. So the wheels start turning. We're like, Hope, does this change the microenvironment? Say it's embedded in our kidney, for example. If you were to look at this, and we haven't done this study yet, but these are all studies that we want and hope to do, look at these tissues, and are we seeing microplastic deposition in these tissues with patients with renal cell carcinoma, right?
Welcome back to BackTable Urology. As always, my name is Ruchika Talwar, and I'm a urologic oncologist in Nashville, Tennessee. Today, I'm thrilled to be joined by Dr. Sunil Patel, who's a urologic oncologist at Johns Hopkins in Baltimore, Maryland. We're going to be tackling the topic of greening the OR, discussing ways to make surgery more sustainable. Dr. Patel, thanks for being here, and why don't you tell the audience a little bit about yourself?
Yeah, first of all, thank you for having me. It's always fun to chat about this topic, and I think it's really fascinating, and I think it's an ever-evolving field. Again, kind of what Ruchi said, I'm one of your urologic oncologists at Johns Hopkins, and I've been here for about 5 years, and this kind of topic that we're about to embark on really started probably about 10 years ago. And I'm happy to dive into that right now. But so I think the topic of environmental sustainability, and I think specifically how it applies to surgeons and us as physicians, kind of stems, and it's multifaceted. So I think you can look at it two ways. One, just looking at the pure just environmental implications of the healthcare industry, but then also from an oncology standpoint, or what we're learning more and more, potential ramifications of the environmental impact and in carcinogenesis or cancer development. So again, like I said, this started years ago, really in my training, and you have long days in the operating room, and you see at the end of the procedures and the cases, you just see kind of these large trash bags full of medical waste. Some obviously rightfully so that you absolutely need. And then you see just a lot of the packaging. And it really started kind of the wheels turning on, wow, this is a lot. You would walk out of an operating room, you're like, what? There's like six full trash bags. And a lot of stuff is just like, this is just like cardboard and plastic. And this is all really necessary. And so that's what really got the wheels turning. And then there was this really cool National Geographic article published in 2018. And the reason why it sticks with me so much is the cover of the article. And National Geographic is really notorious for having these beautiful cover pieces. And the cover piece for this was, and the title was Planet or Plastic. And essentially the image was an upside down plastic bag, almost mimicking an iceberg, and kind of alluding to the analogy of like, we only know the tip of the iceberg and there's so much more underneath. And it, again, the cover really talked about kind of what the implications are, what plastic and what the human civilization is doing to the environment. And essentially they kind of stated like 18 billion pounds of plastic ends up in the oceans every year. And so then you look at that, you're like, are we contributing to this kind of problem that's going on in the world? And sometimes we isolate ourselves, like, oh, yeah, we're in the healthcare industry. We have to do this. We have to do this, right? Like whatever, it's for sterility, it's for this, right? But is it? And I think that's where that question really kind of stemmed from. So that was really the kind of, I guess, the tipping point, so to speak, which started me really being interested in this kind of topic.
Yeah. So you quantified the amount of trash that we all contribute. But let's talk a little bit more about the magnitude of what we contribute in the operating room. Are there any figures out there? Has anyone looked at this before?
Yeah, so I think if you look at kind of contemporary data, each year, roughly, American hospitals produce about 6 million tons of medical waste. A large portion of that waste in the healthcare system is actually produced in the operating rooms or theaters. And about a third of that is plastic. And so you can just think about a lot. So 2 million tons right off the top of the bat is just plastic. And as we know, I mean, plastic comes in many shapes and flavors, so to speak, and kind of different compositions, and each are recycled in a little bit different way. But you think about it, okay, that's 2 million, or at least 2 million tons of medical waste per year that we potentially can recycle.
Mm-hmm.
And I think a lot of that is, and we can talk about it a little bit later, is about the contamination process and how we can do a better job. So I think with long story short is we produce a lot of waste, and specifically in the OR and also in the L&D suites and labor and delivery suites as well. So it's a good amount of trash that we're putting in the environment.
Yeah, so there's trash as it relates to, the sterile drapes, maybe supplies we're opening and that. But there's also contributions from other aspects of the operating room, right? Like anesthetic gases and all that. So tell me more about some of those non-trash related ways that we contribute to climate change potentially.
Yeah. So if you want to break it down into, I think there's like 3 main components, right? We have like medical waste trash that we use for supplies and trays. I think then you have the other one, which you alluded to, which is anesthetic contribution to the carbon footprint. And then we also have energy HVAC use. I think those are 3 big kind of components to it. So we alluded to the medical waste. And if you look at the anesthetic, there's a very, very high carbon footprint of the anesthetic waste. And there's been a lot of new changes to changing some of these anesthetic components. Essentially, like desflurane is about 50 times more carbon intensive than SIVO. And so I think a lot of people have understood that and are making changes. And I'll kind of highlight that in a little bit. But I think that's one big component is how we can actually change the type of anesthetic we're giving to decrease the carbon footprint. But then also, we historically have always, in the operating room as well as in hospitals in general, are very much ignorant to the fact that we leave lights on or leave things plugged in unnecessarily. And that does contribute to it. And I think that there was a study that found about almost 63% of the energy is idle energy that we're not using. And so just to put things into kind of general, like just imagine just leaving your AC going and all your lights on at the house on while you left. You would never do that, really. And so why do we do that here? I mean, I'm sure all of us have walked in the operating theater late night at one point during an add-on case and every single room light's on, every single thing's plugged in, your monitor's still plugged in beeping. And like, why are we doing that? And so those are the 3 components of kind of specifically about kind of how we can reduce a carbon footprint.
Yeah, so we talked about the anesthetic gases, maybe switching to something with a smaller carbon footprint. We talk about maybe turning off the lights in the operating room, unplugging the monitors when you're leaving, or for example, if a room is closed, not going to be used. While we're recording this, I'm thinking of the fact that right now in Nashville, it's fall break. So the operating rooms are running a little thinner than usual. And I bet you all those lights and monitors are still on in those unused rooms. Tell me what we can do about the actual supplies. So let's go back to those drapes, those clips, all the things we use to actually perform a successful surgery. I know I'm guilty of this. Sometimes I ask to open things that I don't end up needing. That seems like an easy place to start. But what are other things we should all be thinking about?
Yeah, and I think if you want to get it really specific, I guess, for urologists, right? So I think we can even break that down even more to even outside the operating room and even on the wards or even clinics. So just basic stuff that sometimes we all forget. A lot of us use syringes, normal saline bottles of irrigation, catheter tip syringes, and all these things. Yes, there are contaminants, right? Those catheter tip syringes and the 10C saline syringes that we take out fully catheters with, right? So those technically cannot really be recycled, so to speak. However, those bottles of irrigation that we're pouring in, those NS, normal saline bottles, those 2 liters, whatever, those are all recyclable as long as we are able to actually just not contaminate it, pour it in a medical contained cup and then recycle that. That is one area that we could all do better on. And again, all of us are guilty. We're trying to deal with someone's hematuria, irrigate their catheter, and we just forget about that, right? Another aspect kind of just escalating now, going into potentially like a procedure center or an ambulatory surgery center or cystoscopy suite, so to speak. Then we get into the whole concept of reusable and single use. And there's always been a point of contention and debate on the calculations of these. And this has been pretty well studied, in my opinion. There's been several papers out there. I helped contribute with 2 papers in this space, specifically looking at single use versus reusable. So if you look at the single use, you have to think about, one, the production of them 2, you have to look at the packaging and shipping of them. 3, you have to look at the actual, when you talk about production, like the actual sheer volume of plastic and materials used. And then 4, the waste, right? And then you look at the reusable ones. And so you have that fixed kind of production, shipping, and the materials used to develop that device, but then you have the sterility component to it. And then that's where it gets a little bit, I guess, dicey, and so to speak, in terms of how you do these calculations. And so there was a study back in, I believe, in the Journal of Urology, I want to say in 2018, and essentially it was the analysis of looking at the LithoVue, which is a single-use scope, versus a reusable Olympus. Again, it doesn't really each specific brand doesn't really matter. It's just the single use. At that time, those are the most common ones. And so the study really looked at all of these components and looking at the carbon footprint of the development and all the plastic, rubber, steel, electronics, etc. And essentially they found that the carbon footprint for the single use and a reusable was roughly similar. However, the interesting thing about this is, though, in their calculations, they didn't really take into account. So when they're talking about the reusable scopes, not necessarily the repackaging, but the sterilization and the energy used to do all that, the washing, etc. A lot of that does not have any calculations to offset or for an offset for more sustainable ways to do the washing and sterilization process.
Right.
And so that's a huge limitation in that calculation. And so we repeated that kind of study, actually looking at and bringing in some experts in production and some engineers. And we actually found the opposite. So we actually found that the carbon footprint in kilograms was roughly 2.3 for a single use scope, and it was 0.48 for a reusable flexible cystoscope. So again, offsetting that with adding that additional calculation. So that's a pretty big difference if you think about it. And if you think about the volume of cystoscopies that are done in the United States, hundreds, potentially even 100,000, like thousands and thousands of them, right? So that does make a difference.
Yeah.
And then then you escalate this whole topic into the operating theater. And so then kind of what you alluded to, the operating room tray. So I think that's another big point of contention. And I know there's a lot of healthcare systems are thinking about that, and I'm glad they are, but a lot of us have like a procedure that's pretty uniformly done. So a robotic prostatectomy, a nephrectomy, a cystectomy, etc., which usually most surgeons use roughly the same amount of materials or instruments for those cases. And so that prepackaged tray or the OR package for that case sometimes may have a lot of extra stuff. So case in point, that's an area of where we can do better, where departments or physicians who do the procedure can work together to come up with a more meaningful, like, hey, in this tray, let's do all of these. And then each individually can open up separate things. It can help reduce excessive purchasing of materials, decrease the number of excessive stuff that's in that tray as well. And then kind of what you alluded to, and I think this about the materials that we're using in the operating room, and are we thinking about it in a sustainable way? Yes, there are certain situations in a procedure where, you need things available because it's a very high risk surgery. And we all get that. But for the vast majority, there's not that many times in the situation where it's a very emergent, otherwise we're compromising patient care. And I think a lot of us would agree on that there are very few situations where we didn't have a suture available. It just maybe delays us a minute. It's not a patient care gets compromised. So I think that's another thing. And I think a lot of us learn that when we're doing a lot of international health, we see other healthcare systems throughout the world, and not just one country. It's predominantly uniformly throughout the world where nothing is opened until that surgeon actually needs it, because they're so conscientious of the items that they need, whether that's due to cost incentives. A lot of other healthcare systems, notably country that I go travel a lot to in Western Africa is Ghana, is that patients have to provide these supplies. And so we have to think about that, right? And then I think that's something that we need to think about. In the US, it's a little bit different, but it does contribute to the decrease of waste. And we see that in other healthcare sectors all throughout the world. So I think those are the kind of the different ways that we could all think about reducing our footprint, so to speak.
Yeah. I mean, so many great points. I think I tend to be cost conscious, just given my specific interests in healthcare expenditures. And so I'll often ask, hey, have this in the room, but don't open it. Like, have the tray in the room. I'll let you know when to open it. And I think that's a good takeaway for us to consider doing so we can be mindful of our carbon footprint as well. I have a question for you that came up as I was listening to you speak, and we may not have the answer to this, but I'm just curious your thoughts. As we move towards more and more minimally invasive techniques, whether it's laparoscopic surgery, whether it's robotic surgery, endoscopic, has anyone looked at the difference between traditional open surgery and some of these minimally invasive surgeries from a carbon footprint perspective?
Great question. So I love that question because you and I are thinking very similar. We wanted to do that. And so we actually had a team here look at it. So we had a really great medical student that was very interested in this. And one of my colleagues as well, one of our reconstructive urologists here at Hopkins. So we looked at the intraoperative waste catalogs, looking at endoscopic cases, open, robotic, essentially. What we found was that the endoscopic cases had the least carbon footprint. So patients undergoing whole lips, ureteroscopies, laser lithotripsies. And I think we can all agree that, there's not that many items being used, even like the drapes and all that stuff. It's quite minimal. There was a very little different or a very low carbon footprint for that. And then you look at the robotic and open. And so if you're looking at the open, so to speak, we see that the open has higher amount of pure waste in terms of medical contamination, where the robotic has more waste attributed to packaging. And so it's because, and if all of us have been in a robotic case before, if you look at it, each robotic arm has to get that drape put on, right? We have to open up each individual robotic instrument with that packaging, right? And so there's a lot of that waste that just adds up. So that's all stuff that could be recycled too, right? Mm-hmm. Minus the robotic arm drapes, right? Those are contaminated, so we cannot use that. Both trays, though, if you look at robotic and open, all of us know that in the infamous blue drape or the blue packaging, that is something that's recyclable. That is something that can easily be recycled.
But do people recycle it? That's my question. Does it go in the red trash bag?
So that's the problem. People don't recycle that. And it's so interesting because it has a component of polypropylene, which has ability to be recycled. And again, it also has a component of something that I study in terms of carcinogenesis, which we can talk about in a little bit. But it doesn't. But there's a lot. So that's where the open waste, it added the sheer volume of trash was a lot of those, because when we do open, we have multiple trays. We have our standard tray. We have our, say, if we're doing a cystectomy, we have a cystectomy tray. Sometimes we may need extra long instruments. We may need different types of retractors, right? And so there's a lot of that waste, so to speak, for that. So, but it doesn't really get recycled. And that's the problem, I think, with these components. But long story short, endoscopic, very little carbon footprint, and I think we're doing a decent job at that. Open, we have a lot of carbon footprint, but those are stuff that potentially has a higher yield of recyclability. And robotic, laparoscopic, I think laparoscopic is, if we did a sub-analysis, laparoscopic was the lowest. Robotic had one of the highest for areas that just had pure just trash, so to speak.
Yeah. And not to mention, every aspect of the Da Vinci system requires power, right? So,
Correct.
The console needs to run on power, the actual robot needs to run on power, the towers. So I'm sure that there's a lot of electricity used in that case.
Correct. And that's something we'd even account for in this. And so that'd be another way to look at that and be like, okay, now let's look at that. Let's also look at, you can even take that one step further and look at the power, but also look at the anesthetic gases. We all know that there is a period of when you're doing some of these robotic cases where you're not operating, but you're positioning, all that stuff. And it's almost like a whole production, so to speak, sometimes. And so, you're spot on that potentially may be adding to things. And I think the way you alluded to, sometimes we don't think about these things, right? And it's none of our faults, right? I don't think any of us are being malicious. I think it's just, we just don't think about it.
Yeah. Well, give me some examples on how you've successfully been able to reduce your own carbon footprint or maybe your institution's carbon footprint.
So one was, this was done still previously back in the day when I was a resident, and all of us have seen the Boston Scientific stent packaging, the original stent packaging, which I'm sure all of us remember. And it was in that big, thick plastic, very firm plastic container. And it was one of those ones I'm like, why are we using all this plastic for a stent? We had to maintain the integrity of the stent. I get that. We can't have any fractures in this tubing because they can have retained foreign objects. I get that. But it was something that we did speak with the industry, and I think through several discussions with leadership at the hospital, as well as the industry and a lot of people who were invested in making some changes, they were able to change that plastic packaging into almost this new paper sleeve, which reduced their plastic kind of consumption. I think it was like between 60 and 70% per stent, which is amazing, right? And that was really fascinating. It was one of those kind of situations where we highlighted something, people were really able to listen to us and willing to listen to us, and came up with a pretty good solution without major compromise in terms of our integrity. And it was great. And I think that's something that all of us could do. I know we all like those, even our powered staplers or our energy devices, right? They come in these massive boxes, all this. I'm sure there are better ways to do it, and I think we just don't highlight it. And I think that's the next step, is to do that. So I think one is for packaging, that's one area, and that's been a big success. Two, I think if you're going to change things at the healthcare level in the system, each healthcare system operates a little bit different. And I think so it's there's no one size fits all, so to speak. And you really, it requires multiple people to be invested in it. And I think it's not just on us, meaning surgeons. I think you need to have colleagues, anesthesia, you need to have OR leadership, you need to have nursing staff, all invested into it. So case in point, this is a little bit different than the sustainability and recycling, but we had a very similar initiative. We're talking about essentially first start, like getting our patients without delaying surgeries, right? And there was an issue, and we've made significant changes, and we've done much better. It was essentially first start on time initiative, and it was involved the scrub techs, operating room nurses, pre-op nurses, anesthesia, and surgeons. And so it was a huge panel of people, and we each had a representative from each department. And we used to meet, and we had our kind of champions from each division kind of take lead, and we were able to change it from like a first start below 50% to over 75, 80%, which is great. None of that would have been done without, if it's just one-ended, right? If it's just a surgeon getting get in the room quick, right? You can't do that. Similarly with this is going to be one of those ones, because, which I highlighted and alluded to a little bit earlier, was the fact that a lot of these wastes, a lot of this recyclable waste happens before the patient enters the room, right? Before there's any medical contamination. So if you have your anesthesia team on board, the scrub techs, the OR nurses, and everyone else, hey, the patient's not in the room, everything we touch in here can be recycled. Since the patient's not in the room, nothing's been contaminated. That's where you make the big headways, but you need everyone to buy in. So I think it requires initiative, and you just got to create that. And I think the best way to do it is I emailed OR leadership and said, hey, this is what we want to do. Is this feasible? And let's send some feelers out and see who's interested in it. Let's create a little team. It's a slow process. It takes time. But if you can, there are numerous people that are passionate about this that we just don't know. And I think they don't know how they can help. And I think if we bring it up to their attention, they'd be more than willing to.
Yeah. I think it's to your point, multidisciplinary. It requires a lot of stakeholder buy-in, and it needs to be like an organized, coordinated effort. Because you're right, there's just lots of moving parts here. Let's pivot a little bit. And you referenced your work in this area a few times, but I want to dive in a bit deeper. We've talked about carbon footprint and potentially our contribution to climate change in the operating room. But now let's talk about how climate change potentially affects our patients. There's been some data out there to suggest that all of these changes we're seeing on a global scale are affecting carcinogenesis. So tell me about your work in this area and what you've learned.
Yeah, so after kind of looking at all of this and looking at the medical waste. And you just see these landfills full of kind of this trash and medical waste and plastic. And then you think about and you understand, so plastic can be broken down by UV radiation. And if they're sitting in the landfill, they're getting some sort of UV radiation to get broken down to their components. And you have this concept of microplastics as well, right? And so we know that these are being embedded into our soil, but now we're learning it's being embedded to more than that. And so if you look at microplastics, so microplastics are technically defined as plastic particles less than 5 millimeters. And now we're seeing microplastic particles in pretty much everywhere. So food, particularly seafood, salt, drinking water, and we're actually seeing microplastic particles deposited in human tissue. So we're seeing them. There was a study done with, it's essentially a cadaveric study, and they looked at multiple cadavers, and they found pretty much in lung, liver, spleen, kidney, all of those tissue had microplastic in the tissue deposited. That's not a normal occurring phenomenon. So we know it's something that we're ingesting. And of course, as the plastic use increases and we have them in our landfills, they're going to get broken down into these microplastics and get absorbed into our bodies. And then you raise we all understand the concept of tumor microenvironments. And so these are considered foreign objects, right? Microplastics aren't normal. They're not natural occurring things in our bodies. So then the wheels start turning, like, does this change the microenvironment? Say it's embedded in our kidney, for example. If you were to look at this, and we haven't done this study yet, but these are all studies that we want and hope to do, look at these tissues, and are we seeing microplastic deposition in the tissues with patients with renal cell carcinoma, right? We've all had these patients who it makes no sense why they develop the cancer, right? They're young, no genetic background or abnormalities. You run genetics on them. There's no family history, and they're 45 and they developed a T3 kidney cancer. Like, why did he develop that? Or the 38-year-old who developed bladder cancer, who has never smoked a day in their life, no secondhand smoke exposure. And you're like, what is going on? And so all of these things in our practice, and I'm sure you've seen it, I'm sure a lot of people who listen to this podcast have seen that. And it just begs the question, why? And so that's what really started me to be like, okay, we need to investigate this. And luckily, there's been a lot of support and a lot of interest in this topic. And a lot of these conversations were started and kind of highlighted at Beacon, so Bladder Cancer Advocacy Network, the meetings at the think tank. And we've had people like Seema Porton, who's been a big fan and component of it. And she's done a lot of work with the firefighters. They have a very unique exposure to PFAS, which is a polyfluorinated alkaline substance, the forever chemical. It's in kind of fire retardants and a lot of like our Gore-Tex stuff. And so our firefighters have a significantly higher levels of PFAS in their bloodstream and in their urine. And they do have a higher incidence of bladder, kidney, and prostate cancer, specifically for the urologic cancers. And so we have people like Seema who's really doing that stuff. And then you have our team like Philip Bosch, Bishoy Faltas, and we've been speaking about this at the Beacon recently. And most recently, we just decided to create a huge coalition. A lot of us urologic oncologists, not just us, but also patients, also veterinarians. There was a really cool study by Lauren Trepanier, who's a doctor of veterinary medicine, and she studied dogs and looked at dogs and their owners and looked at the urine kind of substrate and looked at the alkaline exposure and arsenic exposure for the dogs and humans were similar, and dogs developed muscle invasive bladder cancer.
Wow.
And so you see these associations. Of course, we haven't proven any causality. We're just we're right now in the era of the associations, but we're at that tipping point, which we recently discussed at Beacon, was we need to now do the next step and to now take it to the lab, run animal models and see what's going on. But that's kind of where the process is. So these ramifications are the use that we have in the operating room or in the healthcare system have this other trickle down effect potentially. Again, all hypothetical right now, but one can see that we're seeing carcinogenesis rates go a little bit higher, especially in younger patients. We don't know why. We're seeing smoking rates go down, but the incidence of cancers hasn't really changed in bladder or kidney. So why are they developing it? So one has to wonder, is it something that we are leaching or contributing to leaching in the environment, whether that's plastic byproducts, BPAs, which are bisphenol A, which is an endocrine disruptor, and it's a plasticizer as well. And we've seen associations with higher levels of that in men and women with bladder cancer compared to the standard person, or PFAS, or even arsenic, which is seen in well water. So there's a lot of these kind of now waste, and now how that leaches into the environment creates all these greenhouse gases, but now how does it affect the human? So it's almost a vicious cycle.
Yeah. I mean, that's a great overview of this idea of carcinogenesis from the environment and changes that, we may be contributing to, given a lot of our contributions to the trash that's collected in the operating room. I recently saw some interesting work that was looking at the global temperature changes and associations with increased kidney stone incidence too, because we know that people get dehydrated in the summer. The stone belt in the United States historically is that southern region that I'm in. And so as I can attest to, in the summer, the kidney stone incidence really spikes. Is there any other work out there looking at temperature changes, maybe as it relates to other health conditions that you know of? I mean, kidney stone's an easy one, but I'm sure there's other stuff out there associated with like dehydration. I'm sure someone's looking at CKD, for example, or something like that. What are you aware of?
Yeah, so the dehydration makes complete sense, obviously, from the stone standpoint. So you're spot on. So there's a team at the NIH that's really looking at water consumption and the increased water consumption too now. So potentially increased global temperatures, increased consumption of water. And some epidemiologists hypothesize that actually the increased consumption of some of this water may increase the carcinogenesis based on the volume, because you're getting more parts per million. So it's a study that we've been talking about. And again, I'm no expert in this. I'm not an epidemiologist whatsoever, but I will tell you this. I'm just going to plug her name in because she's a brilliant lady, Estella Koutros. She's a PhD epidemiologist at the NIH, and her work is just fascinating, incredible to listen to and learn from and try to collaborate with. But that's something that they're really kind of hypothesizing and thinking about. So it's very interesting you brought that up, because this is something we just started talking about this summer, and it makes sense from an epidemiologic standpoint. So it's kind of interesting.
Yeah. Looking forward to seeing how that work shakes out. Now, a lot of us are eagerly awaiting what surgery looks like in the future, whether that's AI, which, hearing you and talking about how much energy robotic surgery consumes, I know like AI is probably going to be another huge drain. I've already read lots of information out there about how even using ChatGPT uses a certain amount of water because they have to cool their generators.
We just got to put the generators under the ocean like China.
Yeah. But I'm wondering, what do you think the future will look like in terms of measuring our carbon footprint in surgery? Now, I know that it was interesting a couple months ago, actually it was with the prior administration, CMS had announced, the Centers for Medicare and Medicaid had announced that with some of their new programs, they were creating this voluntary reporting of carbon footprint, and hospitals potentially had the ability to be rewarded. Now, that no longer is in play right now, but I do think, in the future, just pending how the political climate looks, that could certainly come back. This idea of carbon footprint measurement and reporting and being rewarded for a low carbon footprint. But tell me where you see us going in the future. Like, do you think we'll ever get to a day where there's like a counter that tells us, at my institution, when I am finished with a case, I get an alert that says the cost of supplies in your case was X amount, so that I'm aware of it. Do you see us doing that with carbon footprint?
I think that is a brilliant idea. So I think a lot of healthcare systems do kind of what you were talking about, alluded to, the cost, right? I think a lot of us get that report, like on average, this procedure cost this case was X under or X over. And obviously, as long as you're averaging, right, that's great. But I think that's something that they're kind of very attuned to. And we can talk about the finances a little bit, because I think there's a lot that ties in with the kind of financial implications of this. But I do think that that's something that's very warranted, so to speak. I think we're all stewards of this planet, right? And I think we all need to do our part, right? We do great by take care of our patients, but we could potentially do more. I mean, if you look at just the healthcare industry, so the healthcare industry represents roughly around 18% of the US economy, right? And 10% of the global economy. So healthcare is like very uniquely situated to have some sort of say in it. And I think
Mhm.
the vice versa. So there is, since, okay, you are utilizing a lot of resources. So we may need to put you and hold you accountable. And I think that's something not unreasonable to do, right? I mean, I think if you have surgeon A that uniformly does a procedure with X amount of equipment, but surgeon B is overutilizing equipment for who knows what reason, I think that's very completely, it's actually learning. And I think it's not, again, surgeon B may just not know that. They're just like, oh, I actually didn't know that. There was no metric to get. I think we all do well with metrics, right? It's,
Yeah.
even when we're in training, we need some sort of metric, like how am I doing? Where am I at, right? And now as we're faculty, what are my metrics? How are my outcomes for my patients?
Yeah, surgeons are competitive people.
Correct. We are. And I mean, to be fair, why don't we could leverage that? Why don't we leverage that innate competitiveness in all of us? Like, okay, let's all push each other to be better. So I do think that's something that is on the horizon. I would be 100% for that. And I think it's something that's not unrealistic to do. And it's something probably that could be easily done already. I mean, they're counting all that. They just have to get a calculation and have some people do the proper calculations, and they can easily give you the assessment based on the operating room time. You can look about all the energy, your waste, and the anesthetic use, and you can get like, hey, this is your footprint for this case. And yeah, some cases, as we all know, not all cases are the same. So some may be faster, some may be slower, just based on patient disease process. So I think that's a really interesting point.
Yeah, you alluded to this a moment ago when you made the comment about finances, but tell me, what are your thoughts about the relationship between healthcare cost and carbon footprint?
Yeah, so I think the reason why there are a lot of healthcare industries have not widely adopted kind of green initiatives, so to speak, are the financial implications of it, potentially. And so I think the one thing is that a lot of us are led to believe, and some rightfully so, that the recycling is not what it used to be, and not all things get recycled appropriately, and they just end up in the trash. So why are we doing it, right? Recycling does cost more than standard potential medical waste. However, if you look at certain studies actually refute that, and they say no. So one thing that's really cool and fascinating is that UCLA specifically actually has been able to successfully launch a very good OR Green initiative. And they've had some good data published on that, specifically like on the blue wrap. And they've worked closely with healthcare leadership to kind of promote this and show that they can get savings. And so they were able to start reusing and recycling the blue wrap. And they found, on a review, they found roughly almost $700,000 saved annually with about a 30% reduction in medical waste. That is win-win if you think about it. Yeah. In a healthcare system that's operating on millions and millions and millions of dollars, some would say $700,000 is a drop in the bucket for them. But that's still a win. You can put that $700,000 towards another initiative. You could do so much with that money, whether it's research, whether it's a new patient initiative. And then you get the benefit of reducing your medical waste. Mm-hmm. It doesn't matter if it's 30%, 5%, 10%. If we're doing better, we're doing better. So I think that we need to congratulate UCLA Health for doing that. But I think it's one of those ones where we need to take this data to the executives of the healthcare system and show that, hey, I know that you think that this is not financially incentivized. However, we are going to disprove you, and we're going to show that. And hey, here's an example. We were able to do that in San Diego when I was a resident as well. And so I think there are ways that you can prove it to the healthcare system, like, hey, no, there are financial incentives to do this and support it.
Yeah, it's great to know the two aren't mutually exclusive, and that like you said, there's a potential win-win there. So as we wrap up here, share some of your final thoughts with the audience. What are some big takeaways from this often quite daunting, depressing topic of climate change? Yeah,
so I truly believe this requires champions in multiple kind of sectors, and like how you alluded to, like the multidisciplinary action or ways to do this, right? So it's not, as surgeons, I think we need to be responsible. We are responsible for our patients. We're responsible for a lot of things. And I think this is another thing that we potentially be responsible, not to add more tasks to everyone's daily activities, because I know we are all overworked, but I think this is something that we have to think about long term, right? The implications are translatable for our future generations, our potential kids, our families, our own patients, right? So there are things that it's just not just recycling. It's recycling and decreasing healthcare waste in the hopes to save medical waste, save our planet, but potentially decrease things we're putting in the environment that may contribute to cancer development. So I think that's one way to think about it. Two is you have to team up. You need help with OR staff, nursing, anesthesia, and hospital leadership. And I guarantee you there's going to be someone in each respective field or the disciplinary in that will be willing to support you. You just have to ask around. And I think that's the hardest thing, is to ask. And then it comes to the higher level, right? So I think it starts with advocacy groups, like within our own organizations, whether it's SUO or AUA. I think these are conversations that we should be highlighting at our national meetings. We sometimes talk about the same things over and over again in meetings, and it's just like the same old debate, right? And you're like, okay, let's move on. I'm not going to highlight it, but I think we all know which debates are where it's tales old as time. But I think that's another way to really do this and show people that it is very attainable and there are benefits to the healthcare industry or the financials of the hospital, but also the environment and our own patients potentially. And then I think the biggest thing, kind of which you briefly touched on, is collaboration with the top of the top, right? So AMA, CMS, and really institutionalizing this, because I think if we can do that and get enough people to buy into, all right, let's all work together. If we had every hospital save $500,000 to $700,000 and decrease their medical waste by 30%, that is unbelievable. That adds up.
Huge impact.
That's a huge impact. So just that number is translated for UCL Health, which is a major entity. But we think about it, there are a lot of small healthcare systems that are not these big academic centers that you and I are fortunate to work at. But these other healthcare systems are taking care of a lot of patients, more potentially than sometimes the big academic centers. And so they potentially have a bigger impact on their carbon footprint and the global impact. So I think if we can get to them and reach, and I think the best way to do that are at our national meetings. I think those are the biggest things. And then finally, I think, is coming in with concrete data, right? So all of us, you can talk about all this stuff, but without numbers, no one's going to listen to you, right? It's just like what we do in research and science. So if you can prove to them, like, hey, these are the numbers that have been publicly available and been proven and been published, like, we can do that. And it's kind of hard to argue with that. So I think those are the big takeaways from kind of how we can get this off the ground and more, so to speak, mainstream. And I know that at least within the small urologic oncology community, as the big in the healthcare sector, there's been a lot of support, which I applaud everyone. I mean, even one of your partners, Dr. Scarpato, is probably, I love every time I see her because she's so fascinated about this and wants to be a champion in the space too. So I think there are a lot of people that want to do this. I think we just need to come up with almost like a working group or a task force within the SEO or AUA and to launch it.
Yeah. So many great pearls you just covered. I think to your last point, collaboration is key, and getting this front and center with our national organizations allows us to share our learnings so that we can all be successful, because it's great to hear about UCLA's impact, but that impact could be amplified if we all emulate what they've been able to demonstrate. So love that. And then, lastly, I think this idea of starting at the top with our healthcare policy organizations and embedding this into how we think about healthcare delivery is so important. I'm hoping that in the future, CMS brings back that initiative, because it's like things like, how we no longer smoke in hospitals. That's a no-brainer. It's like obvious. It's the foundation of healthcare. It's like it's unsafe for patients, obviously, but there's oxygen lines running. And so you're putting people at risk. Similarly, when you're wasting a lot of supplies or not recycling, you're potentially harming patients by releasing those microplastics. So that's the analogy I sort of thought of. So great points as we wrap up here. We're so grateful that you took the time to chat with us and really appreciate it.
Of course. Thank you for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening and see you next week.